and there were no food particles. There is no history of epistaxis, and there were no aggravating or relieving factors. Past history, he was diagnosed as allergic bronchopulmonary aspergillosis in 2013 and has taken itraconazole for 6 months. He also took steroids, prednisolone, intermittently. These are some important past investigations. In the general examination, he was conscious, cooperative, and oriented to time, place, and person, well-built and well-nourished with a BMI of 27, no icterus, cyanosis, clubbing, lymphadenopathy, or pallor. JVP was not elevated. And the vitals were stable. He presented with 94% on room air. Examination of the respiratory system. In the inspection, respiratory rate 22 per minute, regular, abdominothoracic, trachea central, apex beat was not visible, chest movement was equal bilaterally, and there was no droop or kyphoscoliosis, no visible sinuses, pulsations, dilated veins, or scars. The skin over the chest wall was normal. Palpation, no local rise in temperature or tenderness over chest. Trachea was central. Apex beat was palpable 1.2 centimeter medial to the mid-clavicular line. Chest movement was equal bilaterally. Chest expansion was bilaterally symmetrical and equal on both sides. Tactile vocal fremitus is decreased on left inframammary and left infrascapulary. On percussion, there was bilateral resonant percussion note on anterior, posterior, and lateral chest wall. And on auscultation, there were left-sided coarse crackles in inframammary and infrascapular area. Sir.
Hi, Akshit, can you hear me?
Yes, sir.
Yes. So that was a case, prototypical case of how a person with hemoptysis presents to. So with this brief background of the history and the clinical examination, I think we would now go about into the theory of hemoptysis. Do we have the consultant from the anatomy there with us now? Dr. Deepak Francis. So I think Dr. Deepak has not yet joined. So while he joins, what I would do is I will just, for the sake of the PGs who have joined, we'll give a brief overview of hemoptysis, the definitions, what we have to know, the types of hemoptysis, the etiology, and a brief overview about how to go about investigating and principles of management. See, in the 20 minutes, it is not possible to actually go in depth into the intricacies of management, but what we can do is just give a brief about the principles of management of hemoptysis. Correct? So with this, we will start off. So most important thing is definition. So what exactly hemoptysis means? So ptysis, for people who are interested in the terminologies, ptysis means to spit out. Hemo means blood. So spitting out blood. So basically coughing out blood is called hemoptysis. So there are a few words in the pulmonology nomenclature which end with ptysis. Most commonly used is hemoptysis. But you also have 3 more ptysis. You have lithoptysis, where the person coughs out stones. That is called as lithoptysis. Pyoptysis means where the person coughs out frank pus. And there's also something called as pneumoptysis, where in necrotizing pneumonias, person can actually cough out pieces of the lung tissue. So basically, ptysis means coughing out, hemo means blood. So coughing out blood is called hemoptysis. So why is it important? It is one of the cardinal symptoms of respiratory system. So whenever we take a history for any patient, any person who walks into the OPD, it is essential that we ask about all the cardinal symptoms. So the cardinal symptoms being breathlessness, cough, expectoration, hemoptysis, chest pain. Now, snoring also is considered one of the cardinal symptoms. So hemoptysis is something which we have to ask everybody. Even if the person doesn't come up and says, I'm coughing out blood, as a part of your history examination, you have to ask everybody with cough, have you coughed out blood? Second, why hemoptysis is important? Because it is the symptom which actually leads to most distress. So people may not come running up if they have cough, but usually if they cough out blood, that is something which immediately people do come to the doctor. And it is a distressing symptom, not only for the patient, but also for the doctor, because those of you who have managed massive hemoptysis do know what catastrophe it can lead to. Third, why is hemoptysis important? Unlike cough, expectoration, or other symptoms, this is one symptom, if massive, can also lead to death. So this is a symptom which should not be neglected. And death usually in hemoptysis, massive hemoptysis, not in mild hemoptysis, occurs because of asphyxiation, not exsanguination, which means that the person lungs get flooded with blood and they die of respiratory failure rather than coughing out lots of blood. So, as per the definition of hemoptysis, it is basically blood coming from the lower respiratory tract, that is from below the glottis, anywhere in the respiratory system. So that is called as hemoptysis. If it comes above the glottis, from the throat, from the posterior nasopharynx, or from the GIT, by definition, it is not called hemoptysis. It is called as pseudo hemoptysis. So anything below the vocal cords, if the source of bleed is there, it would qualify for hemoptysis. Also, very, very important thing for us to understand is that what the person coughs out is not exactly the same as the amount of bleed which is happening inside. It also can happen that the person is bleeding inside but is not coughing out. So this is a very important point for all the PGs to remember, that amount of blood coughed out is not equal to the amount of blood which is actually lost into the airspace. So this is the brief points about hemoptysis. Now, when we talk about history taking in hemoptysis, what is it that we should actually ask? When the person says that he's coughing out blood, always ask, actually, is it blood or not? So ask for the color. So a fresh blood usually is red in color. Sometimes the person can actually have clots of bleeding. So dark black colored things, clots coming out, can be a representation of the old bleeding which has happened. Or sometimes it can also happen in upper GI sources. So gastrointestinal bleed sometimes also can be confused. Then also important that many times people get confused between blood and other colors. So I'll show about some of the pictures of the other colors of the sputum also. The second question we have to ask is it frank hemoptysis or is it blood mixed with sputum? This is again important. Many times if you have purulent sputum with streaks of blood, it is usually an infective cause of hemoptysis. Then volume of blood, you always ask the patient how much blood he has coughed out. So if you just ask randomly, they will tell buckets of hemoptysis, but it usually doesn't happen. People tend to exaggerate the volume because once they cough and it falls on a surface, it spreads over. So usually it is better to ask, is it a spoonful or a half cup full or whatever it is. So usually half teacup corresponds to 100 ml or so, which is actually massive. So it's always essential to try to assess the volume. If the person has a picture, now with the advent of phones, many people do take pictures, or sometimes people get the expectorated blood also to us in packets or cups. So try to look for the volume of hemoptysis. This is very, very important because your whole algorithm changes depending upon the quantity of hemoptysis. Then, as with any symptom, duration, frequency. It's all important. Is it acute onset? Has he been having for a long time? What is the frequency? Very important is the last episode. When did the last episode of hemoptysis happen? If it is active, if he has just coughed out blood on the way to the hospital, again, you have to be more alert. If it has happened long ago, then you might have some time in evaluating. So, very important to ask, when was the last bout of hemoptysis? Then also ask for other sources of bleeding. When the person says he coughs out blood, you ask for epistaxis, you ask for melena, you ask for hematochezia, you ask for skin bleeds. So you want to look whether it is a local cause of bleeding or it is a systemic coagulopathy which is causing hemoptysis as a part of the systemic syndrome. So you also ask for other causes of bleeding sources, then associated symptoms. Obviously, in the part of history taking, you would have asked for the cardinal respiratory symptoms, but what you have to understand is hemoptysis is not always respiratory. You have cardiac causes of hemoptysis. You can have mitral stenosis, which can cause hemoptysis. You can cause infective endocarditis, which can cause hemoptysis. So you can cause pulmonary hypertension, which can cause hemoptysis. You ask for cardiac symptoms. You ask for ENT, upper respiratory, upper airway causes of hemoptysis are also there. So epistaxis, if it is posterior epistaxis is bleeding from the nose. If it is anterior, it is easy. If it is posterior, then what happens is the person actually, the blood falls into the throat and the person actually spits or coughs out blood. So this upper airway history is also important, and an ENT examination also is important. Then also ask for constitutional symptoms, fever, weight loss, appetite loss. This is important because to try to understand the etiology of hemoptysis. Is it an infective cause? Is it a malignancy? So constitutional symptoms. So the history taking has to be complete. Then most important, also from history, try to assess if he has anything to suggest cardiorespiratory compromise. The person is having postural giddiness, is weak, or he's having breathlessness, he's having cyanosis, then it is an indication that probably the person is having massive hemoptysis. So these are all the things I think which have to be covered whenever you ask for a person, whenever a person comes to us with hemoptysis. Now, some other terms which you have to know is pseudohemoptysis. Pseudohemoptysis, as I've said, is actually the person says that he's coughing blood from the mouth, but actually it is not blood from the respiratory system. It is either blood from the oral cavity, blood from the esophagus, blood from the nose and paranasal sinuses, and other reasons. That's pseudohemoptysis. So many times it is very easy to differentiate hemoptysis and hematemesis. But sometimes patients come with a very dubious history. They don't know. They just say, blood is coming out from the mouth. So we always ask, what is the preceding thing? Is it cough followed by blood, or is it vomiting followed by blood? Many times it is easy, but sometimes it becomes difficult. So usually hemoptysis, it is frank bright red in color. Hemoptysis, it may not be frank bright red, can be different color, brown or blackish in color. Frothiness, if there is frothiness, it always indicates hemoptysis. In hematemesis, usually there is no frothy thing. Or if you can have an examination of the expectorated blood, if you have alveolar macrophages, then it is definitely hemoptysis. I think you have to differentiate hemoptysis from hematemesis. Sometimes if you are absolutely unclear, it does happen, then you can also get an endoscopy done first. If endoscopy doesn't reveal any source of bleeding, then it is usually hemoptysis. Then some of the colors of sputum, as I've said, there are three particular descriptions which are there. One is called the red currant jelly sputum. It is actually not hemoptysis. It is a pigmentation. It looks like blood. So this is called as red currant jelly sputum, described in serratia as well as in Klebsiella. Then this is very important. The second one is a pink frothy sputum. People who are getting intubated in the ICU, sometimes you do see this thing, pink frothy sputum, very typical of pulmonary edema. Then rusty sputum is how this is, typical purulent expectoration with very frank streaks of blood. This is not very typical of any infection, but has been described in pneumococcus. So these are all actually not frank hemoptysis, different colors of blood with different etiologies. Then another term which is important is factitious hemoptysis, actually increasing nowadays with the increasing in the amount of psychological stressors and other factors. You do come across once in a while, not very common, but at the same time, this is something which we should keep in mind, that the person feigns or fakes hemoptysis. It is not a true hemoptysis. So this is always a diagnosis of exclusion. You suspect when the person's behavior seems unusual, or he's getting too many investigations, doing too much of doctor shopping. And always whenever the person comes with hemoptysis, especially an adolescent, where you don't seem to find anything abnormal, then you think of factitious hemoptysis, always ask one question, whether attendant has actually seen the person coughing out blood in front of them. Usually in factitious hemoptysis, it doesn't happen. They say that then in the washroom, they coughed out blood and then they show the blood. So factitious hemoptysis is one thing where the person actually bites the fingers or bites the tongue and then actually spits out his own blood. So this is factitious hemoptysis, also called as Munchausen syndrome. Then another term which is there is called as cryptogenic hemoptysis. So we've discussed about true hemoptysis, pseudohemoptysis, the various other colors of hemoptysis, term called factitious hemoptysis. Last is cryptogenic hemoptysis. So this is actually not a type of hemoptysis. Basically, whenever a person comes with hemoptysis, you try to identify the cause. In a vast majority of them, you can identify the cause, but in a small subset, maybe around 5 to 10%, despite the best of your investigations, you will not be able to identify a cause. So that is called as cryptogenic hemoptysis. With the advent of multi-detector CTs, with the advent of good quality bronchoscopes, good focused investigations, the percentage of this is actually coming down. Again, in the last 5 to 10 years, hardly a couple of them where we couldn't pinpoint the cause of hemoptysis, that is cryptogenic hemoptysis. Then, as I have said, whenever a person comes with hemoptysis, other than trying to ascertain whether it is true or not. So once you know it is true hemoptysis, the second important thing is try to define massive hemoptysis or quantify hemoptysis. This is very important because if a person has massive hemoptysis, it is a medical emergency. By medical emergency means you don't want to send the person back home, you keep him under observation, you do everything on a war footing so as to prevent death. So how do you define massive hemoptysis? There is no uniform definition of massive hemoptysis. So different books have given different terms. So this is what is there. So in one day, if the person says 500 ml of blood has come, that is one definition, or 100 to 150 ml of blood per hour for at least 3 to 6 hours is again considered massive hemoptysis. Or the most important thing is the third point. Any hemoptysis, if it leads to respiratory or cardiac compromise, then it is called as massive hemoptysis. Third is a very important point because a person with a healthy lungs can tolerate a relatively large amount of hemoptysis. Whereas if a person has a compromised lung, he's already bronchiectatic, he's already having borderline respiratory reserve, even a small amount of bleeding can lead to respiratory compromise. So in such a person, even a small amount of bleeding would quantify for a massive hemoptysis. So if you have if you identify somebody to have massive hemoptysis, then your algorithm changes, you become more aggressive and you have to be fast. Now, this is about the definitions. So the next couple of minutes, we'll talk about the etiology and source. So as far as the source is concerned, the next talk is about the types of circulation. So we'll go more in detail. But what we have to understand is, though pulmonary and bronchial, there are two broad circulations to the lung. Most hemoptysis is bronchial. That is 90% of hemoptysis is because of bronchial arteries bleeding. So that is the bronchial arteries are the source. Only 5% are pulmonary arteries. And also the second thing is massive hemoptysis is usually bronchial and not pulmonary because bronchial arteries have a systemic pressures in them, whereas pulmonary arteries will have a low pressure circulation. So massive hemoptysis is most often bronchial in origin. The third important source is non-bronchial systemic arteries. Whenever we have a diseased lung, you have collaterals which develop not only from the bronchial arteries, but also from the systemic vessels. So you can have new collaterals forming from the intercostals, you can have from the subclavian. So this is called as non-bronchial systemic source. And up to 5% of hemoptysis are from non-bronchial systemic sources. So bronchial source or a non-bronchial systemic source can lead to massive hemoptysis. Pulmonary, unlikely to cause massive hemoptysis because they are low pressure circulation. Then coming to etiology. There is a huge list of diseases which can cause hemoptysis. I can say at least 100 diseases are there which can cause hemoptysis. So as a student, when we have to localize to a system, so what we have to understand is that even respiratory system is classified into compartments. So broadly speaking, you have airway compartment, you have a parenchymal compartment, you have an interstitial compartment, you have a pleura compartment, mediastinal compartment, and a vascular compartment. So when you have hemoptysis, the etiology can be in 3 compartments. It can be in the airway, it can be in the parenchyma, or it can be in the vascular. Interstitium as a cause of hemoptysis is unlikely except you have certain diseases like DAH. Pleura as a cause of hemoptysis doesn't happen. Mediastinum as a cause of hemoptysis is unlikely, except if you have aneurysms of the pulmonary vessels. So broadly speaking, whenever you have hemoptysis, you automatically narrow down to 3 compartments: airway, parenchyma, and vasculature. So this is how you have to look at it. So the most common cause of hemoptysis is airways. Obviously, if you have an airway disease, it is more likely to cause bleeding. So bronchitis. So the first thing is bronchitis. Commoner things, commoner. So the most common cause of mild streaky hemoptysis is a normal infective bronchitis. So don't always think that any blood is malignancy. So if it is streaky hemoptysis, usually occurs in the context of an acute febrile illness, and it is not alarming. So you think of an infective cause, that is acute bronchitis. Then bronchiectasis is another important thing. Malignancies, tumors. So it can be benign tumors of the airway like carcinoids, which can cause hemoptysis, metastatic tumors, especially renal endobronchial vascular metastasis are very typical for renal cell carcinomas, melanomas, and thyroid malignancies. Then other uncommon causes of airway disease abnormalities include either diaphragm lesions. They are very small abnormalities within the airway picked up only by bronchoscopy and can cause potential massive hemorrhages or hemangiomas, tracheal hemangiomas or telangiectasias, HHT. So these are the minor vascular abnormalities of the airway. Foreign bodies and broncholitis also can cause. So airways are the most common cause of hemoptysis. Second most common cause is parenchyma, infections. So TB in India is the most common cause of a parenchymal cause of bronchiectasis infections. Then necrotizing pneumonias, fungal pneumonias, mucormycosis, aspergillosis, they are called angioinvasive fungi. So they're notorious for causing hemoptysis. So infections are a second important group of hemoptysis. Then autoimmune causes, vasculitis, granulomatosis polyangiitis, then causes of diffuse alveolar hemorrhage like SLE or antiphospholipid antibody syndrome. These are all causes of an autoimmune cause of hemoptysis. Then vascular causes. Vascular causes are not very common as compared to airway and parenchymal causes, but nevertheless, we have to consider them. Pulmonary AV malformations, pulmonary aneurysms, PTE, pulmonary embolism is another important cause of hemoptysis. Then other rare things are also there. So now if you have to summarize, two important sources of blood are the airway or the parenchyma. The third important focus is the vessels. Now, after this, the next important groups are the miscellaneous groups. That is bleeding diathesis. If a person bleeds not only from the airway, but from other sources, then you think of this coagulopathies, trauma to the lungs. Drugs sometimes can cause cocaine, bevacizumab, and idiopathic causes. So no need to discuss in detail about all these things. But if we talk about massive hemoptysis, your differentials are little lesser. So if you have to, when a person comes with massive hemoptysis, the most common causes internationally are bronchiectasis, tuberculosis, malignancies or tumors, aspergilloma, or infections. So these are the 5 common causes of massive hemoptysis. Now, TB is something which is important in India and for students also, and very commonly asked question, what are the causes of bleeding in tuberculosis? I think this is one of the very common Viva questions also. So TB can cause hemoptysis in several ways. In active tuberculosis or as a sequel of tuberculosis. So when a person is having active tuberculosis, the tubercular cavity actually can have vessels in the cavity which can get eroded because of inflammation and can bleed. Endobronchial tuberculosis, also tubercular endobronchitis, is a cause of bleeding. Then third thing is pulmonary aneurysms. Rasmussen aneurysm usually sequelae, but also can be there in active tuberculosis, can have bleeding. More importantly is the sequelae of tuberculosis. So post-TB bronchiectasis, the person will be better healed of TB, but there will be residual TB bronchiectasis that can be a source of systemic collaterals which can bleed. Aspergilloma as a sequel of TB, extremely common. I think every week we would see 1 or 2 cases, and then has also always to be considered in a person with hemoptysis and old tuberculosis. Broncholitis, lymph nodes eroding into the bronchi, leading to broncholitis and hemoptysis is another thing. And scar carcinoma, not come across any scar carcinomas, but then yes, it's a theoretical cause of hemoptysis post-tuberculosis. Now, this is in brief about the etiology. Now, quickly about investigations. Again, history, I have already spoken about all these things. Always ask about smoking, alcoholism. Always ask about symptoms as to vasculitis, skin rash, joint pains, hematuria, hearing loss, eye redness. And then ask about immunocompromised status. If a person is HIV positive, then your differentials are different. Then why do you do investigations? For 3 reasons. You want to identify the source of site of bleeding, if not the etiology, at least the site. You want to know the etiology and to assess the severity. So the 3 important investigations are X-ray, HRCT, and bronchoscopy. X-ray is the fastest thing. Many times it can identify a focal abnormality, which will help us identify the site of bleeding, but sensitivity is much lesser. and you will find a normal X-ray in many causes of hemoptysis. So if you have to ask one single investigation which has the best thing, that is the CT chest, a high resolution multi-detector CT scan. If this bleeding is massive, then always add an angiogram, a thoracic angiogram to it. If it is mild hemoptysis, then angiogram is not compulsory. So in HRCT, multi-detector CTs, you can get a lot of information, because you can look at the parenchyma and you can look at the airway also, as I have said, and the vessels also. As I have said, the three compartments are airway, parenchyma, and vasculature, correct? So a non-contrast scan can give an idea about the airways and the parenchyma. If you add a contrast and if you do a thoracic angiogram, you can also look at the vessels. So you can cover up to 90% of all the etiologies by just doing a HRCT with thoracic angiogram. So you can find an aspergilloma like this case, you can find bronchiectasis, you can find necrotizing pneumonias, or sometimes you can also find such AV malformations. You can see a nice tortuous vessel coming there. It may not always be so obvious, but then if your CT is good quality and the person who's interpreting is good, you can identify pulmonary AVMs on a good quality contrast CT. Now, what does the guidelines say? As I have said, X-ray is compulsory. If X-ray is normal, when do you do a CT? If X-ray is normal, if the person is smoker, you have to do. If the X-ray is normal and the bleeding is significant, you have to do. If the X-ray is normal and the person has a risk factor for malignancy, you have to do a CT scan. These are the very important things which you have to understand. Then, if you're not able to identify the source of bleeding on CT, you definitely have to do a bronchoscopy. So CT angiogram is again very important, as I have said, because it gives an information of the vasculatures. You look at malformations, you look at aneurysms, and more importantly, try to look at hypertrophied bronchial arteries. This is something very important. So how do you define it? Any vessel which is more than 2 mm is considered hypertrophic. So not only the diameter, if the hypertrophic vessel is tortuous, again, that indicates that it is abnormal and probably is also bleeding. Now, coming to the role of bronchoscopy, yes, bronchoscopy is less sensitive than a CT, but it is complementary. Very important to understand that they're complementary tools, HRCT and bronchoscopy. If you do a combination of HRCT and bronchoscopy, in 95% of the cases, you would be able to identify the cause of bleeding. So how does bronchoscopy help us? One, to localize the site of bleeding. If not etiology, sometimes you can just see that the bleeding is coming from one particular segment. Okay, you know that is the culprit segment or culprit site. Then if it's a central airway cause, you can identify the cause of bleeding. As I have said, you can find small tumors, you can find telangiectasias, you can find dilophoid lesions, you can find hemangiomas. These are all small things which won't be seen on CT but can be seen on bronchoscopy. The third important role of bronchoscopy is to take a biopsy. If you have an endobronchial tumor, then you can take a biopsy. Then the fifth important roles of bronchoscopy is in management. Suppose you have a proximal source of bleeding, a central airway tumor which is bleeding, you can always do a procedure to either coagulate, ablate the lesion and then control the bleeding. And in cases of massive hemoptysis, as a rescue measure, not as a primary measure, you can use bronchoscopy to occlude that particular segment by putting a balloon, a spigot, or whatever reason. So broadly speaking, bronchoscopy has these 5 roles: localize the site of bleeding, look for a cause, take a biopsy, or control the bleeding by doing endobronchial ablative measures, or to cause tamponade. So this is one of our cases where the person came with recurrent episodes of hemoptysis. CT was normal, and only thing you saw was a small 4 to 5 mm nodule in the wall of trachea, which was bleeding. That was taken off, biopsied, and ablated using cautery. So bronchoscopy helped us in diagnosis, taking a biopsy, and controlling the source by using electrocautery. So this is a case of a hemangioma of the trachea. Now, CT versus bronchoscopy, as I have said, CT is more sensitive than bronchoscopy, but bronchoscopy can pick up some sources of proximal bleed which cannot be seen on CT. Now, blood investigations, common things: CBP, always, hemoglobin is important, platelet is important, coagulation studies have to be done, creatinine has to be done before doing an angiogram. Also important when you think of vasculitis. When the etiology is not clear, you think of autoimmune causes, then HIV is compulsory, blood grouping, cross-matching, and ABG, also because you have to be prepared. Now, last couple of minutes about treatment of hemoptysis. I don't think we should talk very much into the in-depth about medicines and the things, but principles is what we have to understand. So, control of hemoptysis and treating the underlying disease. These both have to go hand in hand. So, these are two different things. So controlling hemoptysis means you don't treat the disease, but you suppress the hemoptysis. So how do you do that? Medical, interventional, or surgical. So medical is you use cough suppressants. It's very important, not expectorants. Use suppressants, either central or peripheral. Central acting antitussives are more potent than peripheral acting antitussives. Then tranexamic acid is another thing which has been used, proven that it can suppress or control the amount of hemoptysis which is happening while we treat the underlying disease. Second is interventional, that is bronchial artery embolization. This is again not a definitive treatment, but it temporarily stops hemoptysis, sometimes for a long durations also. Then surgical resection is both 1 and 2. It definitely controls hemoptysis and also treats the underlying disease. So surgical resection is by far the most definitive management for a localized hemoptysis. Simultaneously, you have to identify the etiology and treat. If it's an infection, treat the infection. If it is TB, treat TB, and so on and so forth. If it is massive hemoptysis, in addition to controlling bleeding and treatment of etiology, you also have a third component that is called prevention of asphyxiation. This is very important because in mild it is not very important, but in massive hemoptysis, it is important to protect the contralateral lung by getting flooded with blood. So this is one important slide. This is an article which has been published recently in Chest, done from AIIMS, Delhi. So where they've looked at nebulized tranexamic acid versus IV tranexamic acid. So most of us usually give IV tranexamic acid whenever a person comes with massive hemoptysis. So they've given the same dose, 500 TAD nebulized. And what they have shown is that nebulized tranexamic acid is probably better than IV tranexamic acid. This is the first article. But I think more data is required, but this is just I have projected because it is from our own country. Then, as I have said, when it comes to massive hemoptysis, it is always important to secure the airway. Whenever a person is having a significant hemoptysis, going into respiratory failure or hemodynamic instability, you should always try to secure the airway. Better to intubate the person, keep him paralyzed so that it doesn't cough, so that you can use endobronchial ablative or tamponade measures to control the bleeding. So then a couple of slides about how we can cause tamponade. If you have a single ET tube, using a bronchoscope, you can put it into the right or the left side so that one lung is ventilated, other lung is blocked. If you have a double lumen ET tube, then even better. You have one into the right side, one opening into the left side. So whichever side is bleeding, that side you clamp. Then you can use Fogarty balloon. You can use an ET tube and a Fogarty by this side. So if it is the left side which is bleeding, put a Fogarty, upload and ventilate the right lung. So several ways to cause tamponade. This is all temporary measures to control the bleeding while a definitive measure is being done. So I think this is in brief about the principles of management. As I've said, I won't go into the technical details of all of these things. With this, I think I will end my talk because this is mostly for the PGs. I think we should understand the definition, identifying a true hemoptysis, etiology, sources, investigations, and principles of management. I think with this, I will end. We can always take questions later. And I think if you have the speaker for the anatomy of circulation. Okay, I think Akshit will finish off his case. So we will see as how he analyzed, approached his case, and then we will see how we can.
The patient's chest X-ray was done. These were the important lab investigations in which the IgE and AEC was raised. C-ANCA was negative and P-ANCA was positive. Aspergillus IgG was normal and Aspergillus IgE was raised. In the echo, everything was normal. This was the CT scan that was done. Also did a PET CT for the patient.
Akshit, can I just interrupt for a second?
Yes, sir.
Yes. So, as he has said, CT is something which has to be done in any person with hemoptysis. But Akshit, can you also tell why a PET scan was done in this particular case for the audience? Because PET scan is not something which is routinely ordered for a person with hemoptysis. Is there any thought process behind?
Sir, we were just ruling out all the causes so that we can arrive at the diagnosis. And there was also a cavity.
So I think the point here is that definitely CT is required, but PET scan doesn't come into one of the initial investigations for a person with hemoptysis. So usually it is CT, a good quality CT, as he has rightly projected, followed by a bronchoscopy. Only when you're strongly suspecting malignancy, actually a role of PET scan is done. I'm not sure whether PET was done before bronchoscopy or after bronchoscopy in this particular case.
Sir, it was done before itself.
Okay. Yes, please.
Then bronchoscopy along with bronchoalveolar lavage and endobronchial biopsy was done.
So what was the finding? You also present the finding here, no?
Yes.
What you could see here.
Yes.
Can you show the images?
Yes.
Yes. So can I just use the cursor and show the audience what was the finding there? Yes. On the other slide, you can find an endobronchial mass. Yes. So there was an endobronchial mass. If you look at the CT also, this is a very interesting case because you had a history of ABPA.
Yes, sir.
Very important that a person with asthma, when he comes with hemoptysis, then you always think of ABPA. So ABPA per se is a cause of hemoptysis. So this is a case where you already have a diagnosis, a cause which can lead to hemoptysis. But still, because the person was not improving, continuing to have hemoptysis, he was evaluated further and you ended up finding a growth. Correct?
Yes.
So probably there are two different reasons for hemoptysis in this particular patient. You have ABPA, you had bronchiectasis as is there on the CT, and you're also finding an endobronchial growth. So as I have said, bronchoscopy helps us in identifying the site of bleed. Here it is the left upper lobe. Correct?
Yes, sir.
Left upper lobe. And you can also take a biopsy. Biopsy was done. Again, any reason why BAL was done? This is for infections. Correct.
Yes, sir.
So usually when you have a growth, a biopsy will suffice. But this, as I have said, is an uncommon case where you have multiple, maybe more than one reason for hemoptysis. So probably BAL also was done to look for associated infections. Correct. Next.
That the biopsy was done and the biopsy revealed an endobronchial hematoma.
Can you just go to the histopathology and tell for
Yes.
the images there what is there that you could find? So hematoma means that you find structures which are not supposed to be there in that particular location. That is, if you find fat, if you find cartilage, if you find bone in an airway. So in airway usually doesn't have all these things, then you think of a hematoma. So here I think he has shown fat and cartilage. Am I correct?
Yes.
Yes. So that is called a hematoma. So you have a endobronchial hematoma. Do you have contrast images? The other important thing is to look whether it is purely endobronchial or extrabronchial also is there. So if you have a contrast CT, I think you only projected the non-contrast CT. If you have a contrast CT,
then we did only the non-contrast.
Non-contrast CT. So I think here it's very important that if a person has hemoptysis, you'd always do a contrast rather than a non-contrast CT. PET scan usually does not come before bronchoscopy. PET scan usually comes after a bronchoscopy once you have confirmed malignancy. Very rarely PET.
Sir, it was done after the
That is what I was thinking, that
Yes, sir.
it would have been done after bronchoscopy. Once you have found a lesion, once
Yes,
you have
sir.
found hematoma, probably to identify the extent and spread, you would have done before the
Yes, sir.
biopsy would have come. Correct?
Yes,
So
sir.
this is an
Yes.
uncommon case. Usually hemoptysis, it is said that one etiology, one person. But this is a case where you had both ABP as a cause of hemoptysis and the hematoma as a cause of hemoptysis. But I think the take-home message from this case, as he has done shown, do you have treatment also?
No, sir.
Okay. Okay. So do you know what happened to the patient after this? How was he managed?
No.
Okay. So, okay. Anyway, that's okay. So I think his case, as he has rightly said from the history, if you listen carefully, history starts with true versus pseudo. So he has said that there is no food particles associated with froth. So it is actually true hemoptysis. Then the complete history has to come. Investigations also, if you have seen, he has started off with a CBP, hemoglobin, coagulation profile. And actually, before doing an autoimmune screen is not essential for everybody. In this case, if you had done a CT and a bronchoscopy, it would have sufficed, because you would have already known that there is a bronchiectasis, there is some growth, there is a biopsy. But if you don't know the etiology, or if you find a diffuse bleeding, diffuse alveolar hemorrhage, then ANCA, ANA, all of these things have to be done. His case is unique because of the fact that there is ABP also. Again, ABP as a cause of hemoptysis, something which we should not forget. And one of the important teachings from my career, actually Jindal sir, who's there, is my teacher. So always that asthma and hemoptysis, think of ABPA. That is another important thing for the PGs. I think with this, we already come to 11:45. I would request Jindal sir to take over and start off the next session.
Okay, thank you, Nagarjun. I think it is a very interesting and educative case, and you have discussed in detail the approach to hemoptysis and possible causes, etc. I think a lot of things to learn for the PGs and others. I think we perhaps are Dr. Richa perhaps will tell, or Deepak, are we ready to go to the second case now, or is there any presentation in between?
No, sir. We are ready to go, sir. Richa here, sir. Good morning, sir.
Okay, good. So I think the fourth most common symptom for respiratory disease is chest pain. Maybe not the fourth, maybe the first sometimes, or the second. That is a different thing. But one of the very common symptoms with which a patient is likely to present is chest pain, and that's what we are going to discuss. The approach to chest pain in the next case. We already have discussed last time approach to cough, now approach to hemoptysis, breathlessness, and so on. So may I request the resident to go ahead with the clinical presentation, and then I'll possibly the possible causes I shall go into the details.
Good afternoon, sir. Can everybody hear me?
Yes, we can hear.
Yes, ma'am. So the topic for my presentation is chest pain. So this is my patient. One second, I'll just. He's a 74-year-old farmer who came to emergency department with complaints of 1 month history of chest pain, breathlessness, and cough. So coming to the chest pain history, it was a left-sided diffuse chest pain with no radiation, with aggravating factors of more with deep inspiration and exertion, relieving factors which was better on lying down on the same side. Initially, the pain was severe, but it gradually became better over the 1 month duration. Currently, he had only heaviness on the left side. It was not related to food, and there was no dyspeptic symptoms. It was not associated with palpitation, syncope, or profuse sweating. Breathlessness was progressive from MMRC 1 to MMRC 3, 4. There was orthopnea present, but no paroxysmal nocturnal dyspnea. His effort tolerance was only few steps when he came to the ED. Intermittent cough was also present with expectoration. It was non-foul smelling. It was whitish in color, and it was not bloodstained. There was no seasonal or positional change with it. There was no history of fever. There was no significant history of weight loss or loss of appetite. There was no history of seasonal variation of symptoms. Past history-wise, there was no past history of any seasonal breathlessness or wheezing episodes, no past history of TB, malignancy, diabetes, or hypertension. There was no family history of any asthma, TB, malignancies, or diabetes or hypertension. He was a never smoker. He does not chew tobacco. No air cooler at home. No biomass fuel exposure also. Sleep was normal. Bowel and bladder habits were normal. He lived in a pakka house with good ventilation, and he belonged to the lower middle class family. Coming to the examination, his saturation was 94% on room air. There were no palpable peripheral lymph nodes. Trachea was mildly deviated to the right side. Air entry was absent in the entire left hemithorax, and there was stony dullness present in the same areas mentioned above. Other system examination was normal. Over to you, sir.
Sorry, I was just trying to share my screen. See, can you see the slide? No.
No, sir.
Is it okay now?
So we can
Yes,
see.
sir. Now it is okay, sir. Yes, yes.
Yes, sir.
Okay, thank you. I think a very interesting case, although simple as far as the clinical history and examination goes. You see, simple to think of a possible diagnosis. But in medicine, I suppose one is wrong many times, even in simple cases. So here we have a 74-year-old farmer. He had farmer who has 1 month history of chest pain, more on deep inspiration and on exertion. Better on lying down on same side, not related to food, and there are no etc. etc. You have already heard. But so I think if I am given this case as a student, just one fact is apparent that this is one-sided chest pain, and which is better on lying on the same side. That tells a lot of diagnosis for a MBBS student. And the patient also has breathlessness and cough, you see. So obviously it is possibly a lung disease, unilateral lung disease. And if we really go into further in the history, that also tells us a lot of things. The trachea is deviated to the right side. The patient is feeling more heaviness on the left side, you see, and air entry is absent, stony dullness is present. So what more do you want to make a diagnosis here? Whenever all these things are present, the obvious thing to think of is a kind of, there are few kind of causes, you see, few diagnoses which would fit in with such presentation. When the entire air entry is absent in one hemithorax, or the left hemithorax, one is of course obvious is pleural effusion. Sometimes it could be total lung collapse or pleural thickening and so on. So that I think is a very classical teaching, how to differentiate between collapse, pleural fibrosis, and pleural effusion. You see here stony dullness is present again, so indicate again towards the more likelihood of pleural effusion, isn't it? So I think in all probabilities, this history so far, as well as the clinical examination, tells us that the patient has got massive pleural effusion, and the patient feels better while lying on the same side. Again, indicates the same thing. Why I will not think of pleural fibrosis, pleural thickening, or a total lung collapse is obvious. One is that trachea is deviated to the opposite side, and in both collapse as well as pleural fibrosis, it will be deviated to the same side. And of course, the patient feels better while lying on the same side. That also indicates effusion because the other lung is now fully functional. So the problem, of course, in such cases may be later used to find the cause of pleural effusion. Otherwise, the clinical diagnosis, I think, is fairly obvious that he has got a left-sided pleural effusion. And can you tell it now from this? I think you were perhaps going to show the investigations, etc., which I have copied it here. Perhaps you can go on with your further presentation before we discuss it further.
Yes, sir.
I can stop sharing here. Okay.
So this was the initial chest X-ray, the one on the left side on the screen, when the patient was in emergency department, which showed a left-sided massive effusion with trachea deviated to the right side. Then we did a diagnostic as well as a therapeutic tap. Post that, this was the chest X-ray after the tapping, which is on my right side, which is again showing a large effusion, but comparatively better than the first one. So this was the final diagnosis we got after the investigation, meaning a left-sided massive pleural effusion after the examination. And these are the reports. So it was a lymphocytic exudative effusion with cytology also showing positive for malignant cells. So following that, he underwent a thoracoscopic pleural biopsy, which came out to be a primary adenocarcinoma lung.
Okay, can you stop sharing? Yeah.
Yes, sir.
Can you see my slide now?
No, sir.
Sorry, I think I'm. Now?
Yes, sir. Now seen, sir.
Thank you. I'm a bit slow of these things. I think these are this is what has already been shown, that this is a massive pleural effusion of the right side. I think that was obvious from the findings and the history as well. And she has rightly told that this on aspiration turned out to be a exudative lymphocytic effusion with normal ADA levels. And of course, on thoracoscopic examination, it was found to be adenocarcinoma. The question, I mean, what we are going to do is evaluate chest pain in general, you see, because chest pain is one of the most common, but the most vague symptom of pulmonary disease, you see. Vague in the sense because almost any disease, patient, whether it is a pulmonary disease or whether it is a systemic disease, patients complain of chest pain, which is expressed differently, you see. And it always remains a problem to know or to finally commit whether it is just a symptom or it is a definitive diagnosis, you see. Chest pain in any area of chest is chest pain. It may spread to other areas, sometimes spreading down to arms, neck and jaw, etc. It is a wide spectrum in quality, intensity, duration, and location. It could be vague or definitive because we know it could be a very definitive sign of many diseases, which will just come. It could be sharp or dull. And people express pain in different ways. Some people feel tightness, ache or achiness, and a feeling that chest is being crushed or squeezed. It could be sharp, stabbing, or dull. We have to understand all these things, because when the patient comes to you, we do not know whether it is a chest disease or it is some other disease. I think that is the biggest problem for a general physician in particular, or an internist. Unlike, because when a patient comes to me as a chest physician, I will always start thinking in terms of a chest disease, which may not be so, especially in case of a chest pain, because the diagnosis could be, it could be cardiac, it could be orthopedic, it could be GE diagnosis, or it could be just a psychological problem or a psychiatric diagnosis. So that's what I think is the real test for a physician in general. It could be variable duration, lasting for a few minutes. Sometimes it's hours. Sometimes patient can go on complaining for months together, years together. So all these things are very important in making a final diagnosis. So seriousness can also vary. So patient's perception also can vary about, with serious disease or it is a mild disease. But important thing is that the physician should never discard the symptom without exploring its etiology, because I have just told you the reasons that almost any organ in the body can cause pain. Most commonly is the chest pain or headache or things like that. 90% of diagnosis can be made on history. I think in pulmonary diseases in general, I have always insisted that it is the history which makes the diagnosis. So history should include duration, location, and radiation, because all these things are important. We just discussed earlier. Then there are precipitating factors which are important: physical, psychological stress, respiratory effort, coughing or swallowing, and relieving factors, leaning forwards, because all these points may point to a different diagnosis. Whether there are any associated symptoms, presence of cough, dyspnea, palpitation, sometimes syncope, presence sweating, nausea, vomiting, fever, and chills, weakness, malaise, weight loss, etc. And sometimes pain, swellings, leg pain, for example, deep vein thrombosis, pulmonary thromboembolism. So different diagnoses can be made. We are not focusing on pleural effusion for the time being. We are focusing on chest pain. Almost any disease, lung disease, can cause soreness around the chest and muscle pain. Laryngotracheobronchitis patients many times will come with the kind of mid-chest pain. Pneumonias come with chest pain, pneumothorax, collapsed lungs, sudden onset chest pain, you all know. In fact, it is one of the most important causes of a sudden onset chest pain. Pleurisy and pleural effusion, of course, relatively dull aching pain present for a few days to weeks. Pulmonary thromboembolism, again acute pain. Bronchospasm, asthma, and COPD can also present with the heaviness, chest constriction, and actual pain. Many times patients may complain of actual pain, or pleural and parenchymal tumors, pleural tumors in particular, but parenchymal tumors can also present with a dull ache. And if they are really involving the pleura, it could be sharp shooting pain, etc., etc. So some of these causes are vague, but then there are many definitive non-pulmonary causes as well. We have just kind of seen the list of pulmonary causes. Cardiac is one of the most important cause, especially it could be very serious. You see, when patient most of the time, in fact, in India in particular, the chest pain always arouses the suspicion of a heart attack. You see, that we all know. You see. And it is true, because that is more an emergency condition, you see, coronary artery disease, angina pectoris, or myocardial infarction. When the patient first comes, we really find it difficult to distinguish between cardiac, pulmonary, or other causes, you see. Cardiac pain can also be attributed to pericarditis or pericardial effusion, myocarditis, cardiomyopathies, or sometimes relatively rare condition like aortic dissection and so on. Then there are very common causes, you see. The gastrointestinal, heartburn, and acid reflux. You see. Reflux, you all know, is a very common cause of chest pain. Swelling problems related to dysphagia. Sometimes you see cardiac-achalasia or the esophageal tumors and so on, you see. So there, esophageal spasms can cause very severe pain, sometimes which is episodic and severe in intensity. Even gallbladder and pancreatic disease or abdominal diseases can also present with pain, especially in the lower regions of the chest. Muscle or bone-related diseases related to the ribs and chest wall, related to spine, you see the fractures, the compression fractures, or sometimes other soreness, etc., can also cause pain. And spinal problems is a very important cause of chest pain, and sometimes these are frequently missed, like Caries spine or some other spinal deposit and so on. Sometimes even diseases like shingles or herpes can cause very severe chest pain along a nerve, you see. And last of all, like in hemoptysis or any symptom can be caused by simple severe anxiety or panic. I think that is true for chest pain also. When you do not find any true cause, definitive cause, it could be just, and people, especially young girls or students appearing in examinations or some other stressful conditions, frequently express, you see, it is a kind of physical expression of a mental stress that is very common in medical practice. You see that there is some underlying psychological stress which is expressed in one or the other symptoms, and the same is true for chest pain. See. Obviously, the diagnostic test will depend upon the clinical suspicion, and it is always better to follow an algorithmic approach. The two most important tests, I suppose, which are necessary for any chest pain are the electrocardiogram, ECG, and chest X-ray. And further we proceed depending upon the initial findings. Cardiac evaluation may be necessary if the ECG is abnormal, or pulmonary evaluation with spirometry, pulmonary function test, CT chest, CT pulmonary angiography, and so on. And if one suspects, say, spinal abnormality, then we go for the examination of spine. And if one suspects the gastric problem, then one goes for a GE evaluation. You see. That is one is, I think, a simplified evaluation algorithm which I have tried to make, is that history and physical examination for any chest pain would be the most important. And that will tell you a lot about the origin of the chest pain. And you do the two investigations which are most important. One is electrocardiogram and chest X-ray. If they are normal, then you go for other causes, you see, like gastroenteritis, even GE causes, or chest wall, or psychogenic causes, and so on. See, but if ECG abnormal, then we always think of the abnormal cardiac system, like cardiac evaluation with echo, stress test, and angio as required. I think this is generally for cardiologists to decide which all to done, but ECG obviously would lie in the sphere of any general physician or any chest physician as well. That is a must for all cases of chest pain. And second, of course, is chest X-ray. Is chest X-ray is abnormal, in most probability is a is a pulmonary disease, but you all know that chest X-ray would also tell you about the cardiac diseases, spinal problems, the chest wall problems, and many times even the other general system problems. And you direct your investigations according to the suspected cause, you say. Cardiac cause, it is partly a repetition what I have already said. It could be life-threatening, that we all understand, whether it is a simple pulmonary lung infarction, cardiac myocardial infarction, or severe angina, or even pulmonary thromboembolism. I think one has to be more careful and cautious in evaluation of chest pain, let's say. So if it is associated with sweating, nausea, vomiting, shortness of breath, lightheadedness or fainting, irregular heartbeat, and radiation of pain in the back, jaw, neck, upper abdomen, so it could be angina instead of myocardial infarction. And I have already listed the tests earlier, and one has to be prompt in evaluation of such a patient, to say. What is the treatment of prevention? Normally, it would depend upon the underlying cause. Medicine and surgical treatments are available, and they always vary depending upon the cause. And avoidance of risk factors, lifestyle changes, and so on. That is the general steps required, you see. As far as our patient is concerned, that I think you have already concluded that it is a malignancy. Because it is massive pleural effusion, and what you do is pleural effusion. One is, of course, pleural fluid aspiration that was done, and it was fairly indicative of a exudative fluid. And in exudative fluid, we know the causes or differences between exudative and transudative fluids. And exudative, the causes most likely are either infections, most commonly tuberculosis, or tumors, and sometimes even other systemic diseases like the collagen diseases, SLE, rheumatoid arthritis, etc., can all causes the exudative effusions. In this patient in particular, it was exudative, but the ADA was normal. So the common causes, tuberculosis was not really considered, and thoracoscopy was done. This patient was old age, so that also favored the possibility of a malignancy. And it was a well worked out case. Thoracoscopy was done, and it turns out to be a tumor, lung tumor. So lung tumors are important causes of chest pain and pleural effusion. And I think this turned out to be a malignant effusion. I think the lesson from this case is that the causes of chest pain can be very simple, like anxiety, tension, or it could be very serious, like a malignancy, as was seen in this patient. So that's all I wanted to say. Factually, chest pain is not specific to chest disease. That I think is a lesson which one should always remember. And the cause can lie elsewhere, although it was not so in this patient. So that way, that was in a way a rewarding diagnosis of chest pain. Thank you. I don't know whether the questions will be possible or not, you see, in this forum. Or
yeah, admin team, any questions in the audience link?
No, as of now, there are no questions.
okay, then I think that's what I have, because I was not clear, you see, what really to go for chest pain. And the evaluation of each cause of chest pain would be different, you see. But I think that what is important is to remember that the number one, the cause of chest pain may lie elsewhere in the body. And it is important to differentiate between pulmonary, cardiac, and other causes of chest pain. And if there are associated symptoms of chest disease, as were seen in this patient, then this differentiation becomes easy. And thereafter, of course, if the X-ray is abnormal, which was almost significantly so in this patient, then the diagnosis, then the approach becomes totally different, and it is basically it is a approach to pleural effusion or pleural disease, which was done rightly.
Okay, sir.
Okay. So is that all? Thank you.
Okay, then we can conclude the session, sir. Thank you so much for your participation, and thanks to all the other speakers, and thanks to all the audience also who had logged in today. We had a good participation from the audience also. Thank you, sir.
Thank you.
Thank you so much.